Airway resistance is defined as airflow obstruction in the airways. As airway resistance causes obstruction of airflow, airway resistance increased when the patency or the diameter of the airway is reduced. Obstruction of the airflow may be caused by three factors: changes inside the airway, as seen when there is retained secretion; changes in the wall of the airway, as seen in the neoplasm of the bronchial muscle structures; and changes outside the airway, as seen in the tumor surrounding and compressing the airway. When one of these conditions occur, the radius of the airway decreases and the airway resistance increases. This can easily demonstrated by simplified form of Poiseuille's law. Based on the Poiseuille's law, work of breathing increases by a factor of 16-fold when the radius of the airway is reduced by half of its original size. As changes in the pressure equals to airflow divided by radius to the power 4. Clinical conditions that increases airway resistance are COPD, mechanical obstructions, and infections. One of the most common causes of increased airway resistance is chronic obstructive pulmonary disease. This type of lung disease include emphysema, chronic bronchitis, chronic asthma, and bronchiectasis. Mechanical obstruction seen in post-intubation obstruction, foreign body aspiration, condensation in the ventilator circuit. Some infectious disease that include laryngotracheobronchitis, epiglottitis, bronchiolitis. Normal airway resistance in healthy adults is between 0.5 and 2.5 cm H2O per liter per second. It is higher in intubated patient due to the smaller diameter of the endotracheal tube. Airway resistance varies directly with the length and inversely with the diameter of the airway or the endotracheal tube. In mechanical ventilator, the degree of the airway resistance is primarily affected by length, size, and the patency of the airway, endotracheal tube, and the ventilator circuit. In clinical setting, the ET tube may be shortened for ease of airway management, reduction of the mechanical dead space, and the reduction of the airway resistance. However, major contribute to the increased airway resistance is the internal diameter of the ET tube. Therefore, during the intubation, largest appropriate size of ET tube must be used so that the airway resistance contributed by ET tube may be minimized. The ventilator circuit may also impose mechanical resistance to the airway and contribute to total airway resistance. This is particularly important when there is significant amount of the water in the ventilatory circuit due to the condensation. Airway resistance and the work of breathing. Airway resistance is calculated by pressure changes by flow. Pressure changes is the peak inspirator pressure minus plateau pressure, that is the work of breathing. Since airway resistance is directly related to the pressure changes, an increase in the airway resistance means the patient must exert more energy for ventilation. As the airway resistance is the pressure changes by the flow, so when there is increase in the airway resistance, that causes decrease in the flow. Subsequently, there is decrease in the minute ventilation. This is because airway resistance and flow are inversely related. In a clinical setting, hypoventilation may result if the patient is unable to overcome the airway resistance by increasing the work of breathing. Hypoventilation means inadequacy of ventilation to remove carbon dioxide. That results in the increase in the arterial PCO2. The work of breathing imposed on a patient is increased when the airway resistance is high. This creates a detrimental effect on the patient's ventilatory and the oxygenation status. If an abnormally high airway resistance is sustained over a long period of time, fatigue of the respiratory muscle may occur, leading to ventilatory and the oxygenation failure. Ventilatory failure means failure of respiratory system to remove carbon dioxide from the body, resulting in an abnormally high PaCO2. And oxygenation failure means failure of the heart and the lung to provide adequate oxygen for metabolic needs. The airflow resistance of a patient ventilatory system may be monitored using the pressure volume loop display on the ventilator waveform. An increased bowing of the PV loop suggests an overall increase in the airflow resistance. The increase in the airflow resistance may be caused by excessive inspiratory flow or increased expiratory flow resistance. As seen in the picture, increased bowing from the dotted line to the solid line of the pressure volume loop suggests an increase in the airway resistance. Bowing of the inspiratory limb from A1 to A2 may be caused by the excessive inspiratory flow. Bowing of the expiratory limb from B1 to B2 may be caused by increase in the expiratory flow resistance, such as seen in the bronchospasm.